understand that there is a little decrease success rate, especially when you're doing IVF in severe stage 3 and 4 endometriosis. Why? Because those patients stage 3 and 4 are associated with the higher association with the adenomyosis, higher association with the peritoneal implants, higher association with the adhesions, and higher association with the endometrioma. That's the reason. What about IVF or ICSI? Normally, ICSI is preferable because of high fertilization rate, mean number of the embryos, and lower rate of total fertilization failure and triploid fertilization as compared to IVF. What is the role of OCP? Pre-treatment 6 to 8 weeks before IVF and ET improves the outcome by calming down, reducing the inflammation on endometriotic implant, and correction of the ill effect of the adenomyosis. Now, this is very important study, very recent study of effect of endometriosis on embryo quality and development, which clears out all the previous confusing data. They says that there is no significant difference. Means there is no difference in the embryo quality. There is no difference. They compare fertilization rate. They compare fertilization failure rate. They compare fertilization and clinical pregnancy showed a higher trend in endometriosis. In fact, a cohort with reaching a threshold for statistical significance. So, in fact, some of the studies, when there was endometriosis, they had higher frequency of live birth rate. So, what about the natural what FET in advanced endometriosis? Is there any role of natural cycle FET? In natural cycle FET, if you try, there is no difference in pregnancy rate outcome between patients stage 3 for endometriosis and those with the tubal infertility. So you can very well try a natural cycle FET protocol. So overall conclusion from available evidence is subfertile or infertile women with endometriosis may benefit from frozen embryo transfer as against the fresh transfer. We have concluded that. And this result suggests that the woman with endometriosis may benefit from low level of hormonal exposure in a frozen embryo transfer, because you know when you're stimulating the cycle there is a supraphysiological level of E2, and probably that is hazardous. Now coming to what happens, this is about the endometrioma, and we know that briefly there is a focal inflammation, and following the focal inflammation, lot of fibrosis, loss of cortical specific trauma, and there is enhanced recruitment and atresia, and following that there are growing follicle, AMH, atresia. So overall there is a burnt out effect, and this has been discussed. Accidental removal of lot of ovarian tissue when you are doing cystectomy, and there is impaired ovarian vascularization, local inflammation, further compromise, vascular compromise following the electrosurgical complication, coagulation. Now, this is very important slide. Sometime I was wondering, while my earlier days of infertility treatment, I used to I used to ask that why there is an arbitrary level that if the endometrioma, even if it is asymptomatic and if it is more than 4 centimeter, you should do a surgical removal, and if it is less than 4 centimeter and if it is asymptomatic, you should not touch. So here is the answer. The presence of large endometrioma, more than 5 centimeter, at the time significantly decreases the number of oocytes retrieved compared to the contralateral healthy ovaries. And here is the proof. If the large endometrioma, 2.6 number of the follicle, whereas contralateral healthy ovary 4.8. Number of the oocyte 2 versus 4.2. Number of the oocyte fertilizable 1.5 versus 3.3. So there is a definite reduction in the follicle oocytes and fertilizable oocytes, especially when the endometrioma is large. So even if it is asymptomatic, it is worth considering for the surgical treatment. This is another proof. Impact of large endometrioma in the response to the superovulation for in vitro fertilization, it reduces. Now, what happens in AMH, in endometrioma, whether it is symptomatic, asymptomatic endometrioma, there is a progressive decline in the AMH. The ovarian reserve is progressively decreased, and you can see it is a significantly decrease. But good thing about the ovarian endometrioma